This is Dr. Frances Munroe from the George Washington University School of Nursing. Today I'm going to talk with you about the general principles of CPT coding and reimbursement, the evaluation and management, documentation, and common sets of codes that are used to bill for evaluation and management services in the healthcare setting. So if we take a look at the CPT codes, which are the current procedural terminology codes, some of the types of providers that use these codes include physicians, nurse practitioners, also known as qualified non-physician practitioners. This is how we're defined by the Center for Medicare Services. Outpatient facilities and hospital outpatient departments all report CPT codes to identify any procedures that are given during an encounter. CPT code should be used to bill for any evaluation management services that are provided in the outpatient setting. They were developed in 1992 to increase the accuracy and reporting of non-procedural office encounters. There are two versions of CPT codes that we still use, the 1995 version and the 1997 version, which is the preferred one. Both are supported by CMS. However, you cannot mix and match them. Once you use one type, you need to stay with that. When you are billing for the patient's visit, you must select the codes that best represent the healthcare service that you're providing during the visit. The basic format of the CPT code is a 5-digit unique code number. The place and the type of service is specified, whether that is occurring in an outpatient facility or a lab. The content of the service is defined. The nature of the chief complaint is usually associated with a given level of service. And the time that the service is delivered is also mentioned and specified with the code. You may also include codes for any procedures or tests performed in the office, such as any CLIA wave testing, urine dips, rapid strep, rapid flu testing, or any medications or immunizations administered in the office, such as vitamin B12, aerosolized nebulizer treatments, all of the immunizations, flu shots, etc. If we take a look at how the patient interfaces with the codes, let's start first with your external record review. As the provider, before you even go into the patient room, you're taking a look at their records. You're looking to see if there's any correspondence from any specialists. Then you go into the patient exam room and you're talking with the patient, eliciting a history, whether it be brief or detailed, comprehensive. And then your next step is usually performing the physical exam. Again, it might be brief, it could be detailed, it could be comprehensive. You then will look at your internal record review, looking at the patient's labs, any test results, any other documentation that you'll provide that day. You'll incorporate the results of other studies. You may take a look at x-rays, EKG, etc. that are done in the office. All of this will come into play as you formulate your assessment, diagnosis, and treatment plan for that patient. The provider must ensure that the medical record documentation supports the level of service that you're going to report to the insurance company. The volume of documentation is not what's used to determine what specific level of service is billed. There are usually 3 ways that we get to the code. Many of you might seen or used in the past what we know as the encounter or the super bill. This is a paper document that usually has a list of all the codes, new, established, office visits, preventative care, all of the immunizations, lab testing done in the office, and other information as necessary. Oftentimes the provider will fill this out with the patient, hand that to the patient, have them go up to the front, And then one of the front desk people will check out the patient, and they may do some back office coding. They may scrub the claim, as they call it, looking for any errors or any mistakes. For example, if you diagnose somebody with a UTI, you might have forgotten to circle that you did a urinalysis dipstick in the office. And again, one of the front office staff might come to you and ask a question and say, hey, did you perform this test on the patient? Did you want to charge for that? In the old days, many of the front office or back office people were actually putting in the codes and determining the level of service. But over the past 5 or 6 years, especially with the advent of electronic medical records, that practice has pretty much ended, and providers are being encouraged to do all of their own coding. The claims are still scrubbed before they are submitted to the insurance company, but the front and back office staff are not allowed to change the codes or the level of service that the provider has selected. There are several classifications that we use for billing Medicare for an E&M service. We need to look at the type of office visit. Is it an evaluation and management, or is the patient there for preventative services? And then what subcategory does the patient fall into? Are they a new patient, established patient? Are they there for counseling, preventative medicine? There are 3 main components to every office visit that are critical in determining the level of service. And those key components are the history, physical examination, and medical decision making. These 3 key components are very important when selecting the appropriate level of E&M service that you have provided. Let's take a look at the type of patient and how do we define who is a new patient versus who is an established patient. The new patient is defined as someone who has not yet received any professional services from the healthcare provider or another healthcare provider of the same specialty who belongs to the same group practice within the past 3 years. So this gets a little tricky. I have worked in a large group practice where there were 17 outpatient clinics all run by the same hospital system. There were 17 family practices, and if patients were to move to our side of town and yet they were seen at one of our other family practices, that was not considered a new patient. That patient had been seen by another provider of the same specialty, family practice, who belonged to the overall same hospital group practice within the past 3 years. So that patient was actually an established patient because they had received services from someone in the same specialty, in our case it was family practice, who belonged to the same hospital system, which was a group practice within the past 3 years. So this can be very tricky if you belong to a large healthcare system where patients are often seen. Now, if a patient had come to us from pediatrics, and let's say they had aged out and they were now 20 years old and wanted to join our family practice, they were considered a new patient because they did not come to us from someone in the same specialty. Pediatrics and family practice are different specialties. Same thing with adult internal medicine. Same thing if they were seeing a specialist in our hospital system. Again, they would be considered a new patient because we were not in the same specialty. If you are looking for more clarification on any of these terms, this is an excellent document. It is the Evaluation and Management Services Guide that was developed by the Center for Medicare and Medicaid Services, CMS, and you can download that right from the link on the bottom. So let's take a look at the elements that are required for all of the components for coding. The first one is the history component, and as you can see from the table here, all of the activities comprising each of these elements is included. All 4 elements indicated across the row must be met for each type of history. And take a look as the type of history becomes more involved, the elements required to perform that type of history also increase in their level of comprehensiveness. So for example, if a problem-focused history requires the documentation of the chief complaint and a brief history of the present illness, take a look in contrast to the detailed history, which requires the documentation of the chief complaint, an extended HPI, an extended review of systems, and the pertinent past family and/or social history. The documentation of the chief complaint is required for all levels, but the extent of information that you gather for all the other elements related to the patient's history really depends upon your clinical judgment and the nature of that chief complaint. Just a quick refresher for you, the chief complaint is a very concise statement that describes the symptom, the problem, the condition, or the reason that the patient is coming in to see you. The history of present illness, also known as the HPI, is a more chronological description of the development of the patient's present illness. Again, we use the old carts to describe the HPI. There are two types of HPIs here, the brief and the extended. If we look at review of systems, again, it is an inventory of body systems by asking a series of questions in order to identify any signs or symptoms that the patient may be experiencing or has had in the past. And again, to review, that is a head-to-toe review of systems. There are three types: problem pertinent, extended, and complete the head-to-toe. A problem pertinent review of systems just talks about the systems that are directly related to the problem. An extended review of systems inquires about that system plus a limited number of additional systems that may be associated. Past family and/or social history consists of a review of those three areas: past history including any illnesses, surgeries, treatments, family history, and then the social history that is age appropriate. Let's take a look at the next component of the CPT code, and that's your physical examination. Again, as we go down the list, the level of the E&M service gets more extensive as the type of examination becomes more comprehensive. We usually start with the problem focus, which can be a very limited exam of just the affected body area or the organ system. And as you see, 1 to 5 elements are identified by a bullet in one or more organ system or body area. The expanded problem-focused physical is a limited exam of the affected body area or organ system and any other related areas or to do with other symptoms. The detailed physical exam is an extended examination, includes at least 6 organ systems or body areas, and at least 2 elements identified by a bullet is expected for each area. The comprehensive is a general multi-system physical examination, or otherwise known as a complete examination of a single organ system or organ systems. It includes at least 9 of those systems or body areas, and for each area or system, documentation of at least 2 elements identified by the bullets are expected. There are some important points to remember when you're documenting your physical examination. Make sure that you include any abnormal or relevant negative findings, pertinent positives, pertinent negatives, and you want to include any organ systems that are found to be either abnormal or any unexpected findings of the examination. A brief statement indicating any negative or normal findings is sufficient to document related to unaffected areas or asymptomatic organ systems. The last component of our CPT codes is medical decision making. The chart below looks at the elements that you need for each level of medical decision making. And again, in order to qualify for a given type of that medical decision making, 2 of the 3 elements must either be met or exceeded. Medical decision making refers to the complexity of establishing or formulating a diagnosis or your management plans. And so you're going to look at the number of possible diagnoses, the number of management options, the amount or complexity of medical records, diagnostic tests, or any other information that must be obtained, reviewed, analyzed. And then lastly, the risk of any significant complications, comorbidities associated with the patient's presenting problem, the diagnostic procedures, and possible management options. So again, we look at the level of complexity going from straightforward to high, the number of diagnoses going from minimal to extensive, and the amount and complexity of data and risk of complications going from minimal or low all the way to extensive or high. There are some important points that you want to keep in mind when you're documenting your diagnoses or management options. For every encounter, you want to document the assessment, the clinical impression, or your diagnosis. You want to be very explicit in stating your documentation of any decision making regarding your treatment plan, further evaluation. You want to mention in your diagnosis in the record whether the patient is improved, well controlled, resolving, or whether a problem has completely resolved, whether it is inadequately controlled, whether it's worsening or failing to change as you expect. So this is very important to add on. We don't often see this in the electronic records, but it is helpful if you can put that in. If you are making any changes in the treatment plan, that should be documented, including patient instructions, nursing instructions, therapies, medications, diagnostic testings. You certainly want to document if any referrals are made, if you're asking for any consultations or any advice, if you had any collaboration with your collaborating physician. And then the record should also indicate when that took place and what decisions were made as a result of those consultations. You certainly want to look at the complexity of any data that you are reviewing, and if you want to obtain medical records for review in order to look at past medical history. You certainly want to document if there are any unexpected test results. And you certainly want to review any type of lab or radiology imaging and talk about the interpretation of those tests in your note. And lastly, you want to consider the risk of any significant complications, comorbidities, mortality. And again, that can go anywhere from minimal to high. Some important points to keep in mind would be any underlying diseases or other factors that increase the complexity of your medical decision making because of the increased risk of complications. If there are any diagnostic procedures that are planned or scheduled at the time of the visit, and if any are performed at the time of the visit, the specific procedure should be documented. And any referrals or decisions to perform any diagnostic procedures should also be documented in the record. This is known as a table of risk, and what you want to take a look at is the presenting problem. Again, if we look at the minimal level of risk, it's one minor problem. It could be an upper respiratory cold, insect bite, a minor skin condition, Any diagnostic procedures ordered, again, they may be some lab testing done right in the office. And then some of the very simple minimal management options selected. Usually here there are no written prescriptions for any prescription medications. These are more educational or comfort measures such as the rest, gargles, superficial dressings. When we go to the low level of risk, this may be 2 or more minor problems, 1 stable chronic illness such as well-controlled hypertension, diabetes, BPH, any uncomplicated illness or injury. Again, this would incorporate most of the things you're seeing, such as pharyngitis or otitis media. Again, the diagnostic procedures are usually pretty minimal. And then the management options, here this would include your over-the-counter drugs, minor surgery, physical therapy, occupational therapy, maybe some IV fluids. As we move up that table of risk to moderate and high, you can see now we're adding many layers of chronic illnesses with exacerbations, side effects of treatments, undiagnosed new problems, acute illness with systemic symptoms. They give the example here of pyelonephritis. You could have scarlet fever, acute complicated injuries. And again, the type of testing you're going to do becomes much more involved. And the management options are again much more extensive, including possible surgeries, prescription drug management, different diagnostic studies. When you get to the high level of risk, these are your patients who are pretty sick, whether they have 1 or more chronic illnesses and severe exacerbations such as a COPD or asthma exacerbation that's severe, acute or chronic illnesses that could pose a threat to life or bodily function, multiple trauma, acute MI, etc., or an abrupt change in neurological status such as a TIA, seizure, or stroke. Here, your diagnostic testing is going to be much more extensive, as will your treatment options. So this is basically a nice diagram of how it all works together. You're going to use these tables to calculate your level of medical decision making. You're going to take a look at the problems, the number of problems, the type of data, and you're going to put your points in to come up with your equation and your findings of your level of risk. Remember that 2 of 3 elements are required. So how do we determine the code? Well, first of all, we have our new codes and our established codes, and we take a look at those key components, whether it be the history, the physical, the presenting problem, and then the time factor. We don't usually code on just time alone. That was something that was done in the past, but we do consider time as a factor, especially for things such as counseling. One thing I'd like you to take notice of is that each of the new and established codes are off usually by just 1 digit. So the 99201 new matches up to the 99212 of the established. They are linked this way because many times they have to meet the same types of criteria. The charges are also very similar, so when you're billing patients, you want to keep that in mind. These are the preventive medicine codes. These are our well-child physicals or our adult routine physical exams. As you can see, all of the codes, the new and the established, are one right over each other. And these are the age groups that we would see those in. Certainly, you can try to bill for some counseling. It is very difficult in a family practice setting to get reimbursed for this. There's a lot of documentation that is required if you do this. But again, there are the codes and the criteria mostly on the time and the quality of counseling that you have done. So let's take one example here and code this scenario. Let's take a look at our 70-year-old male patient. And as you see, he's here for follow-up of congestive heart failure, diabetes, hyperlipidemia, and arthritis. He certainly has multiple comorbidities. He has been stable on his current regimen. His A1C is improved with increasing doses of insulin. He's controlled on statin therapy. His renal insufficiency and arthritis are both stable. He's been doing very well. He's had no other symptoms. He is following up with his doctor, and he has had no other concerns today. He is on the following medications: Bumex, aspirin, lisinopril, insulin, Zocor, Toprol, and Protonix. There are the results of his physical examination. As you can see, his blood pressure was a little elevated when he first arrived and the nurse took it. I repeated it later and it did come down. There are his labs also for you to review. So for our assessment and plans, we're going to combine them for the purposes of this exercise, and you can see his CHF is stable. We'll continue the same regimen. His diabetes is improved. Hyperlipidemia is well controlled. And his arthritis is stable. He's going to follow up in 3 months. We told him not to worry too much about the brace. For now, he's going to continue with his cane and walker. So let's take a look at what type of code we might use for this patient. And if any of you were guessing the 99214, you are correct. This is an established patient. And so for this visit, that requires 2 of the 3 components, either a detailed history, a detailed physical exam, or medical decision making that is moderate in complexity. We might want to look at the counseling and coordination of his care with his other healthcare providers and the patient or family needs. Usually the presenting problem is of moderate to high severity, and typically about 25 minutes are spent face-to-face with the patient and family. So if you take a look in the coding book, the CPT 2014 or 15, the professional edition, if you look under the main term evaluation and management, office and other outpatient, the coder will have you go and look at the codes 99201 to 99215. And the very first determination that the coder is going to verify is whether this is a new or established patient. So as they're reviewing your charts, they're going to take a look and see, has this patient been seen before? We know that he has. This is a follow-up visit, so he is established. So we're just going to look at the codes 99211 to 99215, which are appropriate for the established office visit. So for this encounter, we see that 2 of the 3 key components must satisfy the documentation in order to assign the appropriate level. We're going to use the 1995 guideline for this example, and we want to make sure that the medical decision making and history meet or exceed the requirements for a level 4 established visit. The examination in this case does qualify as an expanded problem focus. We did examine 4 organ systems, and so that meets the requirements for a level 2 or 3 established office visit. It doesn't affect the code selection, as only 2 of the 3 components are needed for each level. So if you would like to practice coding some more of these scenarios, you can go to this website, which is the Optum 360 website, and every month they have a new Code This Scenario, and I think you will enjoy that. Here are some other helpful resources similar to what I shared in the ICD-10 lecture preceding this. Again, the American Academy of Professional Coders, the Health Information Management Association, the AMA, and additional resources are available through the CDC, CMS, Healthcare Information and Management Systems, the Optum 360 site, and the World Health Organization. Thank you.